The odds of hemophilia in Greg and Olga's offspring. Let's start off with learning about hemophilia. Hemophilia is a rare genetic bleeding disorder where the blood does not clot properly. The two main types of hemophilia are type A and B. They are very similar, but are caused by different genes.
Hemophilia is a recessive sex-linked disorder that only affects the X chromosome. Therefore, it is more common in men than in women. The F9 gene is responsible for type B hemophilia. The F8 gene is responsible for type A hemophilia. This is the type that runs in Greg and Olga's family. The function of the F8 gene is to make coagulation factor 8, which is essential to the formation of blood clots. The cytogenetic location of the F8 gene is XQ28, the long arm of the X chromosome at position 28. Mutations of the F8 gene result in altered or missing protein that cannot be used for blood clotting.
The symptoms of hemophilia are, in a mild case, inability to properly clot blood once injured, and in a more extreme case, spontaneous bleeding may occur, as well as blood getting into joints and causing severe swelling and pain. Here is a pedigree chart of Greg and Olga's family history with hemophilia. The shapes filled in black are people who have hemophilia. Carriers are not shown. Because Olga's brother has hemophilia, Olga's mother must be a carrier. Therefore, Olga may or may not be a carrier of the recessive hemophilic gene.
This Punnett square shows the likelihood of Greg and Olga's offspring having hemophilia if Olga is a carrier. In this case, there is a 1 in 4 or 25% chance that the child will have hemophilia. This Punnett square shows the likelihood of Greg and Olga's offspring having hemophilia if Olga is not a carrier. In this case, there is a 0 in 4 or 0% chance that the child will have hemophilia. Since it is undetermined, there is a 1 in 8 or 12.5% chance that the child will have hemophilia.
There are two prenatal screening options to test the child for hemophilia. One option is chorionic villus sampling, where a fine needle is inserted through the abdomen to take villi cells from the placenta. This is done when the fetus is between 11 and 14 weeks of age. The other option is amniocentesis, where a small amount of fluid is removed using a fine needle inserted into the uterus. This is done when the fetus is between 15 and 20 weeks of age. There are two treatment options for type A hemophilia. One option is replacement therapy, where concentrates of clotting factor 8 are slowly dripped or injected into a vein. The second option is desmopressin, which can only be used for mild cases of type A hemophilia. It is a nasal spray or injection that stimulates the release of stored factor 8 and increases proteins that help with clotting.
The risk of replacement therapy is that if the patient has strong antibodies, they may destroy the clotting factor. This happens in 25% of type A hemophiliacs and 3% of type B. It also can be pretty expensive, but the clotting helps prevent damage, swelling, redness, pain, and more to joints and muscles, as well as reducing the risk of issues after a cut. Desmopressin works very well for mild type A cases, but doesn't work in severe cases or type B. It wears off pretty quickly, but in mild cases can be used only when needed and is very effective. Overall, replacement therapy is a better option because it works 100% of the time provided that there aren't strong antibodies. You don't have to worry about having a sudden cut that was at an unexpected time, and it works for all types of hemophilia, not only one.
In conclusion, Greg and Olga should not be concerned about their child inheriting hemophilia type A because there is only a 12.5% chance of the child having it, and if the child is affected by the condition, it is treatable so the child can still have a happy and healthy life.